Good.
Yeah.
Okay.
Awesome. Well, I can't wait to get the next installment of the story.
Almonds, yes. Okay, where would you like to start?
Well, as I recall, the last time we checked in, like you were getting some results back that were a little concerning, and we were kind of in that muddled of like this could be something or it might not be something. You were going to go get an ultrasound, or no, you had an ultrasound and you were going to go get.
But I hadn't met with, no, I think I just met with my primary.
Yeah.
And
Yeah.
she said, "Oh, this is not good. I'm going to hook you up with my favorite gynecologist."
Yeah.
So yes, right. That was about 5 weeks ago. I had a DNC and they put in an IUD. And then it took several more weeks after that to get the iron infusion thing going, because I had to fight for that. That's a really interesting. I've learned a lot, and it seems to be that standard of care does not consider someone iron deficient, even if they are technically iron deficient with the 3 stages. And would it be useful to go over those, do you think, for prospective audience?
It will, but let's roll back to what a DNC is.
We'll start there.
because DNCs are being discussed in all sorts of different contexts right now.
Absolutely.
And so I think we should take an opportunity to just talk about what that is and why they did a DNC based on your lab results, and then why would you do an IUD if you're menopausal? Like, that's confusing.
It is confusing. So, right, we'll start with, in our last installment, we talked about how the ultrasound showed that there was a very thick uterine lining, and that was a big part of the reason why I was having so much bleeding. And when there's such a thick lining, the standard of care is to make sure that that's not happening for any kind of sinister reason, like due to uterine cancer. So they want to get in and take a look and see what's going on. And then to remove as much of that uterine lining as possible, just so you don't continue to bleed and bleed and bleed. So DNC stands for dilation and curettage, and it means that they actually manually open up the cervix. You do not feel this. And then, at least what they did in my case, is the surgeon, she vacuumed out the insides after taking a quick peek, mostly so she could see things better. And what she was looking for is there a uterine polyp, because those bleed a lot, and she did find one small one. And or are there fibroids? And there are several different kinds of fibroids, but was there a fibroid that might be the culprit also with the bleeding? And she found one small fibroid. I had a pre-existing, pretty darn large, what we call intramural, like in the wall fibroid that we already knew about, but that probably wasn't causing some of this problem. But so the surgeon, she actually removed the smaller new fibroid and removed the polyp, and both of those got sent off for biopsy to make sure that there was no cancer cells or anything, and everything was hunky-dory. And then the curettage part of dilation and curettage refers to actually a tool where they literally scrape out the insides of the uterus. So because this is a fairly invasive procedure, they don't want you conscious when you're doing this much activity. Although this is a procedure that's also used for early term abortion, and that is not as extensive of a scrape out as what I got to go through. So that's why DNCs are coming up a lot.
Yes.
In current media, because they are one of the procedures that are used for eliminating a pregnancy that is not viable or unwanted at an early stage. And so do you feel like, is that enough about?
I think that's enough. I just really wanted to, and I think that's a great education, and partly because I think this is a great example of like DNCs are really valuable medical procedures.
They are. Yeah, they serve much more purpose than
and serve much more purpose. And so, but right now, depending on what state you're in, doing a DNC or saying I had a DNC can cause all sorts of red flags that may or may not have anything to do with a possible pregnancy or a possible abortion. And so I think it's important to keep medical procedures available to doctors to because the next stage of taking care of a uterus that's bleeding hard is even more invasive, right? Like it just escalates. And so yeah, I just wanted to take a pause and like really define that. You did a great job defining it. And then why'd they put an IUD in? And like,
Right. So an IUD, the most common form of IUD that's used is, the brand name is Mirena, and it is infused with progestin, which is synthetic progesterone, and slowly secretes some of this progestin over a period of 5 to 7 years. And when you have a little bit of extra progestin inside the uterus, it slows down the uterus's ability to build up new lining. So after a couple of months of having an IUD, most women, whether they're using this for birth control or they're using this to control bleeding, which is the case for me, although I get the bonus of birth control as well, since I have a male partner, you end up with much lighter periods. And some people experience, about 40% experience no periods, which, I mean, yay. I had one of these 6 years ago. I had one for over a decade, and that worked out for me. I didn't bleed for a decade. It was phenomenal. It was great. But I chose to remove mine 5, 6 years ago because my mother got diagnosed with breast cancer, and there is a very small potential link with using synthetic progestin and increasing risk for breast cancer. But on the flip side, if you have a little bit of progestin in something like an IUD, it decreases your risk for uterine cancer. So it's all a bit of a trade-off. And I am more than willing to accept any very small potential risk by using something like this for the benefit of not bleeding like a crazy person, which is great. And so the idea is that it will stick around for, we'll keep tabs on things. And once I finally pass through to menopause in a few years, then we'll take it out.
Yeah. Excellent. Awesome. Thanks for that detour on uterine health. And then
I do want to add like one little personal comment. I was surprised because my experience with DNCs for patients, for example, typically don't require general anesthesia. Most of the time they do it without anesthesia at all, or just a little bit of light sedation like you would see with colonoscopy. But because of the nature of this kind of DNC, it is quite a bit more vigorous and invasive. So they actually conk you out. I was totally freaked out about having general. It worked out just fine. It was fine. Wasn't even nauseated. Right. But I was that obnoxious person. It was a good education moment for me because the nurse that was taking care of me before I went into my procedure, she was asking if I had any questions. I'm like, can't we do this with like a spinal or just some conscious sedation? And she looked at me, she said, no. And let me tell you why. Which was exactly what I needed as a type A healthcare person. It was like, I can work this out. I can bargain. She's like, no. We need you totally unconscious. We're going to be moving you in weird positions and it's painful. You don't want to experience that. So that was a good learning curve for me.
And had you been on general understand?
No, and that was part of the, not that I was worried I was going to die on the table or anything.
Yeah.
Those irrational fears, but I definitely felt depressed the next day because general definitely has an impact on the brain. And I'm not in a big hurry to do anything like that again, but at least I feel a little more confident, and it is magical.
It is pretty magical that they can put you out and you feel nothing and not even have a lot of visceral body memories of it to speak of. Right. And were you sore the next day?
I was definitely sore for several days and just super slow. Everything just felt really achy and boggy, almost like you can get with a really gnarly period. Yeah. I didn't bleed a whole lot right after the procedure. I have had 2. I'm finishing up my second, like 10-day long little dribbly period. Come on.
Hopefully it works it out and just stops.
Yes, yeah. I presume in a few months it's all going to settle out, but right now it's still confused, shall we say, because the progestin, although in the long run it inhibits uterine growth, in the short run it helps actually flush out uterine growth. Yeah. So anyway. Yeah.
And generally my experience is with any female reproductive changes, like I'm always telling people, give it 3 months. Like it takes 3 months for the body to sort out. Like if you start hormones, or you start herbs, or I'm like, it's not instantaneous. Like, the body's pretty complex and it likes maintaining homeostasis. And
I think that's a great rule of thumb.
So, and generally it works itself at the end of 3 months. And if it's shorter, bonus, but like, that we have more importantly, we have a marker that if 3 months goes by and things don't get better, then we know we need to do something more.
Yes.
So, okay. So that was the procedure piece of it. And
that's control the bleeding. So you're
control
not
the breathing.
Iron.
Yes.
That's the goal of that. And we took care of that. Yeah.
Right.
But
now we have to, we stop the leak in the bucket,
mm-hmm.
and the bucket is really empty. So what are we going to do about that? So what I do as a physician, and I think Alethea does as a physician at a certain point, is we're just going to get you some iron and fill you up. Yes. How did that discussion go?
So what I found was that let's pull back and review, because there are 3 formal stages of iron deficiency. And this is my understanding, and please chime in if it's different for you. With stage 1 iron deficiency, you have low iron stores, and that's what we measure with ferritin. And anything ferritin under 20 is technically considered iron deficient. And then stage 2 is when you have that, plus your hemoglobin and hematocrit, which are your frank measures of iron in the blood, are below normal. And then stage 3 is when you have the first 2 and your actual red blood cell count is low. And the reason why I'm pointing this out is because the experience that I had showed me that standard of care doesn't believe in treating beyond like oral supplementation unless you're stage 3. And I was only at stage, I would call it 1B, because with a ferritin of 5, I definitely qualified as less than 20. I was definitely symptomatic. My hemoglobin and hematocrit and red blood cell count were within normal range, but at the very bottom of that range. Because continually through there, like my PCP, really lovely ARNP, was just like, I've never done that before. Because I said, I'm hiking the Alps in 6 weeks. I'd really like to be able to do that. Can we do some iron infusions? And she's like, I have no objection. I don't know how to order it. It was a learning process for her as well. But she consulted, and there was just this unending cluster of, she sent the referral got rejected because of some weird like discrepancy. And it was crazy to me that I was in surgery 4 days after meeting with my PCP for an office visit saying, hey, you've got this really thick lining. We need to take care of it. That was no problem to take care of fast, but it took a month to get the iron infusions scheduled. But thankfully they did. And I also point out the stages because it seems like there is if you're going to do iron infusions, they order 5 over the course of, you do them twice a week or weekly.
Yeah. And who's they?
Your ordering physician, your primary care physician.
Okay.
And there's no deviations, like you do 5 and that's end of story. And then we check in a while and see if it's sticking, as you like to say, sticking.
Yeah.
Anyway, so those got scheduled. I have completed, I only chose to do 4 for a variety of reasons that I'm happy to share, but I did do them.
Yeah.
And they were psychologically creepy as all get out, because it looks like Coca-Cola is going into your veins. And, my personal experience was that each infusion, I had a negative experience with the first one, but in retrospect, I really do think it was coincidental, because I had no problem with the actual infusion, but I had nausea and some GI stuff later. But I really think that was something else, because I had no problem with any of the other infusions. But they made me tired for about 24 hours. And then it would start to lift, which was kind of interesting. And so my understanding from reading about it is the iron, because it's iron sucrose, doesn't go through your digestive tract. So people who are sensitive to oral iron do much better this way. It sinks into your bone marrow within about 12 hours, and its whole job, it will raise the ferritin level quickly. And since we generate new red blood cells approximately every 12 weeks, it's there and feeding the new red blood cells as they are being built. So the full effects are not felt for a couple of months.
Yeah.
right?
Well, I mean, I infuse more to get neurotransmitters going, and
Excellent.
and my patients report feeling less fatigued and less irritable and less anxious within 10 days easily.
Yes. Yeah. And I would agree with that with my own experience. I was fascinated. The very first night, something stood out to me, and I realized that I had been dealing with some mild restless leg. I hadn't even thought, I worked out too hard, or, oh, I'll blame it on my cycle because I can blame everything on that. Perimenopause, the bucket. And I have the most peaceful legs ever since, even just the first one. Energy is so much better. I feel like myself again. I don't feel like Superwoman. I just feel like this is normal. I don't have to nap when I get home. It doesn't take me twice as long to bike home. I think 2 days after my first infusion, I was walking home and there's a hill and it wasn't a slog. So yeah.
So isn't that interesting? So even though we know that you haven't necessarily gotten a big bump in terms of red blood cells and the ability to carry oxygen,
Right.
you've started to get some, but like not
right.
Like they would be like, oh, again, 12 weeks, blah, blah, blah. But like pretty immediate
Yes.
impact, because iron is affecting your ability to make dopamine and serotonin. It's a huge catalyst in your liver for processing like a billion chemicals. I mean, iron plays such an important role. And even with one infusion, like you now feel capable or more capable of hiking a hill at sea level, which will probably help you in the Alps.
Yes, I agree. Definitely.
That's awesome.
Yeah, and it was marked. I had spoken to a friend of mine who had gone through a similar process a couple of years ago, and she said the first infusion she noticed a really big difference, and then they only gave her 2. I don't know why. This is in Portland, not working with NDs. And she said the second one, I didn't really notice any difference. And I feel like with every one, even though they were they were about every 3 to 4 days for 2 weeks, every one, it got better noticeably.
Yeah.
And so, yeah, I'm super excited to see how I feel in another month or 2.
Right.
So it's so worth it.
So worth it. Yes. Yeah. So worth it. So going back to the 3 stages of iron deficiency and if you get infused or not. So one of my pushbacks to that whole system, and because I don't really participate in the insurance system very much, I don't pay attention to those things very much. Yeah. Is there's really good studies, and I'll link that in this video system that women whose ferritin is below 50 get diagnosed with depression because they're complaining of fatigue. Right. So 20 is the low end of the normal for the MDs. 50 is when women start reporting feeling like crap, which means like we want them at 70, 80 kind of range, right? And when you're at 5, and your body's doing a really good job making red blood cells, oxygenating the body, but it doesn't have a lot of resources. And so one of the things that I did out of irritation is I called LabCorp and I asked LabCorp, where did you get these normal values? Because the normal values, depending on the lab, is anywhere between 20 at the low end of ferritin to 250 at the high end, which is
a useless range. Yeah.
Or 150. It bounces around. I'm like, where did you get these normal ranges? Because they're not consistent at all. And LabCorp is the big behemoth. So I called and I was like, hey, I'm a doctor, I have a question, and so they're all like nice and friendly. And I was like, so how did you come up with these normal values? And they're like, well, we took 1,000 normalistic people and put it on a bell curve.
Yep.
And I'm like,
all reference ranges are established.
But I'm like, have you looked at the research? Like,
Right.
well established, like this isn't one or two studies. This is a plethora of studies that are like women feel like crap after 50.
Mhm.
Not after 50 years old, but 50 in terms of the ferritin range. And they're like, we're not required to by the National Institute of Health and the WHO. We just have to do this. And so you can see the gap. So like the primary care providers, God bless them, don't have time to be in the research on every little detail of health, particularly around nutrition
Mhm.
and depression. The standards are set up for, those stages are probably set up for other disease states,
Right.
not women who are exhausted because they bleed every month and they birth children,
Mhm.
right?
Yeah.
So it could be set up for men. It could be set up for all sorts of things, but I'm pretty sure everybody's going to feel like crap with a 20 ferritin. But they're not they're not promoting wellness. They're defining when disease takes place. And I know, Alethea, you know all of this, but I find it very irritating,
Mhm.
right?
I felt very much, sorry to
Go
interrupt,
ahead.
very much like, number one, it gave me a lot of empathy for my patients who have been put in the squeaky wheel. Because I was calling the infusion center pretty much every other day. I'm like, so can we do this yet? Oh, hi, Dr. Fleming. And it's clear they were uncomfortable, like a provider. And yet, but I also felt like I live in a small town, so half the time my infusions were done over at the cancer center, which is a very normal place for all infusions to happen. But half the time they were actually done in the hospital on the weekends on a patient care floor. And the nurse who did all of the infusions on the weekends, I was the second person in 30 years he had ever given iron to. And he was like, whoa, you must be really bad off. I'm like, well, he's like, is your red blood cell count down in the toilet? And I was trying to explain to him, and you could just see, oh, are you just a whiner a little bit in the back of his head?
Right.
And I asked the nurses at the infusion center, and they're like, yeah, we do most of the iron infusions here, because they were giving iron to everybody, it looked like. But I felt very much like, oh, let's indulge her almost, because she's a provider and she's aware. And if I was just a normal patient who was like, oh, I feel like crap, this never would have happened.
Right.
Or at best, I would have been told, take oral iron. And,
Right.
Thankfully, I tolerate oral iron, especially the forms that naturopaths recommend that don't tend to destroy your guts. But it just, oh man, it made me so mad on behalf of my gender, because this is just one more example of ways that it's just like, oh, well, you're a woman. It's just part of being a woman. Sorry.
Right. And we're not going to help you. Right.
Oh, it just made me livid.
Yes.
Still a little bit mad about that.
Yes. And it's impressive that you got the infusion center to do it, because I have tried when I was in Seattle, I had naturopaths who do IV therapies. I could just refer. They were very efficient about it. Like there was no question about, like, I'm like, their ferritin is 30, right? Like not even technically low, but because they had so much fatigue, so much depression, like I was just like, let's clean this up and see how much they improve.
Mm-hmm.
But then I moved to Tacoma, and I was like, people like, oh, I don't want to go to Seattle, blah, blah, blah. It's a long way. I'm going to have to go multiple times. And again, I'm outside the system. And so I don't work in the system particularly well, and have just stopped trying to get into the infusion centers. Mm-hmm. And this helps me understand, like, you had somebody in the system.
Right.
And you're a physician.
And it was still a pain in the ass.
And it was still a pain in the ass, but you got it done, right? Like,
yes,
but barely.
Right. And part of the reason I chose not to do that fifth infusion, number one, I felt like I'm in a really good position. I know that my body I'm not bleeding as much anymore. I can replete with oral iron, which I will do later once I see what my numbers look like just from the infusions. And getting the infusions, it's inconvenient. It takes time. It, makes you tired. But also, I don't have my final bill yet, but the verbal estimate that they were able to give me, I mean, they're going to cost me about 160 a pop. And that's not nothing, but it's not nothing.
Right.
It's like, I think I'm pretty good with 4. That's fine. But right, it was so wild that I had somebody fighting to make this happen for me. I was so well informed, but oh my gosh, it's just such a cumbersome. It just makes it so hard.
Yeah. So is insurance not going to pay for this? Because
oh no, insurance is paying for this. They charge like 8, and insurance picks up most of it, and 160 is supposed to be my cost of that. And for comparison, when I talked to some of the ND infusion centers, number one, they said usually they can get insurance to pay for it with a reasonable copay, and at worst out-of-pocket cost is $265, which again, that's not nothing for a lot of people.
Right.
So this is still not necessarily inaccessible from a hassle factor, but even from a financial perspective for a lot of our patients.
Right. And from my perspective with mental health, when you're looking at somebody who has been flipping meds, which is very expensive, going to the appointments, changing the meds, going through the withdrawals, and fundamentally the meds didn't work because they were iron deficient. No med's going to fix that because that's not the problem.
Yeah.
And so, it's definitely worth paying attention to what the costs are. Like, costs are always costs. And being that fatigue has its own cost. And there's a study that I'll link to this, where Sweden did a study that women inappropriately being diagnosed with something other than iron deficiency was costing their economy like millions of dollars.
How did they do that as a study? How did you get funding for that? That's great.
Millions of dollars,
Hey.
not only of healthcare costs, but and they didn't do like, how much does it cost a woman when she can't clean her house because she's too tired, right? Like, it was how many missed days of work.
Wow.
Right. So like really concrete examples, because they took people who had been diagnosed with iron deficiency and then rolled back 2 years and was like, wow, like finally. And and despite those studies that are readily available, we still fart around with, well, you're not anemic, your blood cells are fine.
Yeah. Pretty frustrating.
So it gets back to, we have to be educated about our own healthcare, and we have to advocate for our own healthcare. And that's partly why I really feel blessed that you were willing to do this series. And we're going to check in probably one or two more times, because there's some science that we want to go back and catch, and I want to hear how the Alps were. But I think it's really important for women to hear that, one, it's just hard to get good health care, even if you know what's right and are educated and have the DR to like muscle people around a little. It's still hard. Right. It's still possible. And like, the more we know what a reasonable storyline is, we don't get so frustrated and give up, right? And you showing us what a reasonable storyline is really generous, and I really appreciate it.
I am happy to do so, because this helps give anybody a little more like, okay, that's worth pushing, because it's really easy when you're in that iron deficient state to just think this is normal, because that's kind of the message we get, because you're, still functional, but not anywhere near optimal.
And a little more energy feels so good, and not caffeinated, right?
Yeah, it's lovely. And again, I don't consider myself to be a particularly anxious person, but I feel calmer already. And I recognize a lot of any anxiety I was experiencing in the last 6 weeks or so had a lot to do with, I don't like people poking me.
That's
who are you? I don't trust you.
That's reasonable situational anxiety.
Absolutely.
Like, you didn't become a naturopath because you love the medical system.
Well, right. It does make me wonder about my colleagues who do nothing but IV infusions all day long. I'm like, oh my gosh, isn't there an herb for this? I'm more old school, I guess. But I'm so grateful that we have this option, and it certainly is going to make me a more conscientious provider. Because I mean, I thought I was doing a pretty good job just by checking ferritin levels on people, but I'm going to be doing it more often and treating more aggressively now that I've had this experience.
Yeah.
So I am grateful for that.
So just to review, with the infusions, you restless leg, unnoticed restless leg got better. Anxiety seems to be lower. Are you warmer? I mean, I know it's hard. It's the middle of the summer, but a lot of patients really notice that like their hands and feet are not as chilly.
That is not something I have noticed, but that's not something I've never, ever since starting perimenopause, I've not had cold hands or feet. But what I did notice is that I had been self-treat, like all my perimenopausal crap is better. Like I'm not having night sweats.
Right.
Starting this, I'm not having to take a bunch of herbs to mitigate symptoms because the fundamental systems are working better. So that's an enormous blessing right there.
Right.
Yeah. Stamina better, both physically, breath stamina. If I'm doing something cardiovascular, I can bounce back more easily. If I get tired, like last weekend, I did a serious hike and I was tired afterwards. And so I just hung out on the couch and read a book for a while, and then I was good to go for more.
Awesome.
Whereas that would not have been the case even 2 weeks prior.
Right.
So, yeah.
Right. I want to just go back and touch on the perimenopausal symptoms better. So one of the things that I often discuss with people in terms of like, menopause is coming, what should I do? I have perimenopausal symptoms, and sort of my tiered approach, and I would be interested because everybody's like, should I do hormones? And I'm like, whoa, let's pull it way back. There are lots of steps that you can do before you go to there. And for me, because my focus on mental health and like, can you synthesize neurotransmitters? Do you have protein, B vitamins, iron, magnesium to synthesize dopamine and serotonin, which then drive the hormone release and balance this? Because I always try and be not smarter than God or evolution because they've been doing it for a while. But this is a great example of like, when you can make your neurotransmitters more efficiently, the symptoms go down. And not that it's bad to do herbs, but the herbs are pushing the hormones, which is the next stage that I'm like, do Western herbs with a naturopath, or Chinese herbs with a Chinese practitioner, or Ayurvedic really great herbal formulas. Try that. And if that doesn't work, then we can have a discussion on that. And actually, I would go back, and I see a lot of benefit of people eating regularly, getting 8 hours of sleep, exercising, and eating vegetables.
Shocking.
I know. Do you have anything to add, or any changes to that kind of like stepwise? Like, what do I do?
How I approach things as a professional?
Yeah.
Right. Always the basics first, without question, because that has such a phenomenal, people don't realize how fundamental those pillars are to supporting the whole system, because it's subtle and because the changes are so small. I mean, they build up over time. And so, right, I start with basics, not as aggressively as you do with your focus in terms of the nutrient status, although I'm expanding my protocols. And then I usually do use herbs. I'm fine with using hormones, but what I explain to most people is often we don't need to. And it's great that we have that as an option. It's safer than we thought 10 years ago, but it's frankly, it's cumbersome, it's expensive. So I typically recommend, let's just use that if we can't get where we want to go with something simpler. And yay, it's a tool.
Yeah, nice. Awesome.
So, although I did notice just what you said made me want to comment on one other symptom change that I noticed. I wear an Oura ring because I'm a nerd. And prior to doing the iron infusions every night, literally for the last several years that I've been wearing this, I tend to fall asleep like that. 3 minutes, I'm gone, which is great. But since then, it's taken me longer in a more normal amount of time to fall asleep. It's like 10 minutes, 12 minutes, which is considered in many ways physiologically more healthy because you're not so exhausted that you're just passing out immediately. So I thought that was an interesting change as well.
Right. And again, it just speaks to that you're less exhausted.
Right. Exactly. So getting, reasonable sleep, that hasn't changed, but
yeah,
apparently it's a little more satisfying. So based on your experience, how long after finishing the iron infusions should I wait to check on iron levels to get a solid indicator of, are we moving in the right direction? I don't want to be premature.
Yeah. So generally what I've seen with the people that I refer is they usually get a ferritin pretty soon after, just to see how much you filled the tank.
Okay.
Right. And then it's I like it every 3 months, because they're and almost no one does it. Like they do 3 months and they're like, okay. And then they're like, oh, we're good. And then 6 months later they come and they're like, oh, I'm so tired. I'm like, let's check your ferritin. And then we find that they went back to homeostasis and we might have to do another infusion. So my recommendation, regardless of since you're leaving on Thursday, probably we're going to skip that stage and just get it. I think it would be interesting to get it when you come back from the Alps, because you're going to have such a big stimulus to make red blood cells, right? Like, so when you go to altitude, I expect that you're going to have a little bit of altitude sickness in that first few days. Like you're going to be nauseous and headachy and really thirsty, because that's the erythropoietin hitting your system.
Right.
And we want a really good erythropoietin response, because that's stimulating your bone marrow to make red blood cells. But it'll be interesting to see how much of a bump your red blood cell count gets.
Right.
Yeah. And just on a side, like it will be interesting, like it's an N of 1, but like sometimes the body changes its homeostasis regulation when you push it hard. And this is going to be a hard push. And so like, it'll just be fun to follow your story and see if you have a significant iron drop, or if your body's like, hey, she's feeding us iron, like, let's keep it.
Cool. Well, I will plan to do labs when I get back.
Okay.
And probably at that point, because I don't have any illusions that I have magically made everything better. So at that point, is it safe to start taking oral iron? Because I haven't been doing that during the infusion process, because that's not recommended. But
yeah, I would wait until you get back, just because like keeping supplementation down when you're traveling is also awesome, and you'll be eating well, and and it'll be interesting to just see where your ferritin is. And then once we know where your ferritin is, then we'll decide on how much supplementation you want to do.
Yeah, sounds good.
Okay. Awesome.
And thank you. Touch base after that information.
Thank you so much. I'm going to hit stop recording.